Hello everyone and welcome to our video on Pediatric Gastroenterology. So just for a quick review, the assessment of the abdomen really begins from the neck and extends all the way down to the knees because of all of the interplay of the structures that are involved in the abdomen. And one of the most commonly used examples of this is the child who complains of abdominal pain but really is diagnosed with pneumonia. Keep in mind that a lot of these diagnostics that we've talked about already in this class can be used for the abdomen as well. For example, if we don't want to give a child too much radiation, we can take a look at their kidneys with a renal ultrasound. Everything that we're going to talk about in this section has to do with fluids, electrolytes, and nutrition. So your approach to any of these conditions should be in 3 steps: fluids, electrolytes, and nutrition. And just a fun fact, about 80% of the body's entire immune system resides in the GI tract. You won't need to know the exact distribution of body fluids. However, it is important to know that the younger the child is, the more total body water they have. This is why they're more prone to dehydration with certain illnesses. It is important to remember that water movement is passive. Water typically follows gradients or other electrolytes, such as sodium and chloride. So keep this in mind as we go through and talk about the next few slides. These are some examples of conditions where you would expect the child to have an increased fluid requirement. Examples include fever, vomiting, and diarrhea. And vice versa, these are some conditions where the child will have decreased fluid requirements, such as heart or renal failure. We're going to be splitting our talk into water and electrolytes. And so for the first section, we're going to talk about water loss. Water loss can occur due to poor absorption, decreased intake, or increased loss, such as vomiting and diarrhea like we talked about before. The clinical manifestations of water loss are exactly the same as the clinical manifestations of dehydration. Some common lab findings in water loss would be more concentrated urine, hence the increased specific gravity, and more concentrated serum, hence the increased hematocrit, BUN, and serum osmolality. The treatment for water loss is to identify and correct the cause, as well as monitor the child's fluid status. You would watch strict I's and O's, monitor their vital signs, and their body weight. And keep in mind, we're going to approach each one of these with F, E, and N. So you're also going to watch their electrolytes, and you would want to check their blood sugar. Now, contrary, there is also water excess, where you have increased intake or decreased excretion, such as the cardiac or heart failure and kidney failure that we talked about a few slides ago. The clinical manifestations of water excess are very similar to fluid overload. Laboratory findings would be consistent with a dilutional urine or serum. For these patients, they'll likely be fluid restricted. And keep in mind, we can do this with both PO and IV fluids. We can administer diuretics to help move fluid from areas where we don't want it, such as edema or pulmonary edema. And again, you'd want to be watching their vital signs, watching their electrolytes, and making sure they're getting adequate nutrition. Now let's talk a little bit about the electrolyte-driven imbalances. such as hyponatremia. Hyponatremia is something that we can see with increased loss of sodium through vomiting, nasogastric suctioning, or any of the other conditions written here. The clinical manifestations are going to be very similar to those that you saw with dehydration. However, in this patient, you would be very concerned for the development of seizures. Again, we want to determine and treat the cause of the sodium deficit, as well as watch their eyes and nose, vital signs, other electrolytes, and monitor for seizure activity. Anytime you hear of a change in a sodium level, think seizure activity. Now there's also sodium excess or hypernatremia, which you can get from excess intake, renal disease, or dehydration in the neonate. And again, many of these signs and symptoms will be similar to dehydration, with the exception of the neurologic findings listed on the right. To treat hypernatremia, we would want to determine and treat the cause of the sodium excess. We would administer IV fluids, sometimes even hypotonic fluids. Watch their vital signs, their electrolyte levels, their intake and output, and again, we would want to monitor their neurologic status closely. Dehydration is a very common condition that we see with multiple different illnesses in pediatrics. Basically, it occurs whenever the total output of fluid exceeds the total intake. There are different kinds of dehydration, and so the types include isotonic, hypotonic, or hypertonic dehydration. Most of the time in pediatrics, we just see isotonic, with hypotonic being the second most common. Now, we're not going to get into how to calculate the level of dehydration for your patient. However, this is a valuable table to kind of help you in your mind get an idea or a frame of reference for how dehydrated your patient is based on the findings that you found. And again, same with this table. Based on your findings, you can get an idea of what type of dehydration they have. Just like with all of the other conditions that we've talked about so far, the management of this condition is focused on finding the cause and correcting it, as well as correcting the fluid balance. If a child is alert, we will always start with oral rehydration fluids, such as Gatorade or Pedialyte. If they cannot tolerate Gatorade or Pedialyte, this would be an indication for IV fluids. When we do use IV fluids, each bolus is typically dosed at 20 mL per kilogram. This really only changes when we're talking about patients with heart defects or heart failure. Some of the treatment goals that we have in dehydration include making sure the child has moist mucous membranes, making sure our electrolytes are back in balance, making sure that they're voiding and that they have good capillary refill. It may take several repeat boluses to achieve all of these goals. Now let's quickly talk about disorders of motility. The most common disorder of motility is diarrhea. Diarrhea can occur from enteritis, colitis, or enterocolitis that you can see above. Diarrhea accompanied with vomiting would be gastroenteritis. There are two basic etiologies of infectious diarrhea. One is bacterial, but the most common by far is viral. In bacterial diarrhea, unless you're immunocompromised, meaning you have a condition that affects your immune system or you're very young, we likely will not treat bacterial diarrhea with antibiotics. The major goal of treating diarrhea is to bring your fluid and electrolytes back into balance. This is going to be very similar to the treatment of dehydration that we saw earlier. Oral rehydration solutions should be administered, but they should be used in small quantities and frequent intervals. So small, frequent sips. And keep in mind that solutions like Pedialyte or Gatorade provide both fluid, electrolytes, and nutrition in the form of sugar. The treatment goals for diarrhea are very similar to the other conditions that we've already discussed. It's good to keep in mind that diarrhea associated with viral illness can last several weeks, and this is not abnormal. The next most common disorder of motility that we see in pediatrics is constipation. Constipation is associated with painful bowel movements, or even just intermittent colicky abdominal pain, as your intestines use peristalsis to try to push that hard stool ball through. When your intestines are trying to push it, the child will be in a lot of pain. When they relax, the child will miraculously look improved. There's a lot of etiologies for constipation. The most common are a lack of water intake, a low fiber diet, or a low activity level. But there are also some other conditions listed here that can result in constipation, as well as it's a side effect of many medications. The treatment of constipation does depend on the cause and duration of symptoms. However, keep in mind that peristalsis is what made it painful for the child. So we'll typically start with stool softeners and not prokinetic agents. Miralax is probably the most common stool softening agent that we use. Children tolerate it well because we can mix it in the things they already like to drink. Vomiting is associated with many illnesses that we've talked about this course in pediatrics. And there are many causes, and not all of them are infectious. It's important when you're assessing any of these symptoms, but especially vomiting, to know about the pattern of vomiting, color of the emesis, and the duration of the symptoms. For example, you don't want to assume that someone has a GI bug when they're vomiting first thing in the morning and potentially have signs of a brain tumor. The treatment of vomiting is, again, right back to FEN. We want to replace the fluids, correct any electrolyte abnormalities, and make sure that they have good nutrition. So you would be checking this child's blood sugar as well. We can use antiemetics, such as Zofran, to help prevent or control dehydration while we are treating a vomiting-related illness. The next condition we're going to briefly talk about is called Hirschsprung's disease, or congenital aganglionic megacolon. You can see here at the bottom that there is an aganglionic portion of the colon, which basically means that when it formed, there was no innervation or nerves. Without nerves, it can't dilate and move like it's supposed to. So everything that ends up going through the colon gets obstructed as it's trying to pass through this little section here. And everything I said on the last slide is basically what this slide says. Due to the obstruction, we find most Hirschsprung disease in the first few months of life. A red flag for this condition is failure to pass a stool within the first few days after you're born, refusing to eat, bilious vomiting, or abdominal distension. These are other clinical manifestations of Hirschsprung disease, as well as a picture of the megacolon part that's distended, trying to pass through the area without nerves. If you can think back to the picture that we saw in the beginning, any stool that actually gets through that really small passage will look ribbon-like, and often, because of the delayed transit time, will smell very bad. Additionally, they'll have abdominal distension, just like you saw in the picture. We can use x-rays or contrast enemas to diagnose Hirschsprung's disease. However, obtaining a biopsy specimen and looking at it under a microscope for the absence of nerves is the definitive diagnosis. Children will require surgery to remove the aganglionic part and then perform a bowel resection. We've all heard of gastroesophageal reflux before, but because you have less esophageal sphincter tone the younger you are, we tend to deal with a lot of gastroesophageal reflux in small children and babies. Infants can't tell you that they have burning in their chest or in the back of their throat, but what you will see is frequent spitting up and regurgitation, crying from the irritation, and potentially poor weight gain or even respiratory problems if they're having microaspirations. Older children will have more similar signs and symptoms of reflux to adults. Children are more likely to reflux when they're laying down or when they have an increased gastric volume, such as right after eating. Therefore, a lot of the lifestyle modifications that we teach parents are to give small, more frequent meals and to burp their children very well. We can also thicken their formula or breast milk with rice cereal, as well as keep them upright for 30 to 45 minutes after feeding. Pharmacologic treatment for GERD includes histamine H2 blockers, such as Pepcid, or proton pump inhibitors as well. While your textbook says proton pump inhibitors are more common, these are actually quite expensive, and so most children will be placed on famotidine first. With severe or life-threatening complications of reflux, they can also do a fundoplication, which you can see pictured here, which basically takes part of the stomach and wraps it around the area where the reflux was coming up. Typically, if we're performing this surgery, they're also having a G-tube placed. Our treatment goals for reflux include making sure the infant is adequately gaining weight. We want to limit spitting up or vomiting. We want them to get good sleep, and we don't want to have any respiratory complications. Now let's talk about a few other GI conditions, and that'll be the end of the lecture. Classically, the child starts with periumbilical abdominal pain, which then slowly moves to the right lower quadrant over McBurney's point. The child can also have nausea, vomiting, and fever, but very infrequently is appendicitis associated with diarrhea. If you have perforated appendicitis and it causes peritonitis, you may see a child with a rigid abdomen. The younger the child is, the more likely that they'll have perforated appendicitis because they can't tell us about their symptoms. A red flag for perforated appendicitis is the immediate relief of pain. Many times we'll try to diagnose appendicitis with an ultrasound. However, if we're not sure and we have a high index of suspicion, we may also do a CAT scan. We'll check other labs as well, such as your CBC, for an increased white count. The treatment for classic appendicitis without perforation is just an appendectomy. Usually you only need a dose of antibiotics prophylactically before the surgery. However, if you have perforated appendicitis, abscesses, or peritonitis, you may need several days of IV administration of antibiotics, as well as bowel rest. The next condition we're going to talk about is pyloric stenosis. As you can see here, the muscle at the bottom of the stomach, in picture A, has hypertrophied, creating a blockage at the bottom of the stomach. This infant will eat, their stomach will fill up, but it will be unable to pass. With pyloric stenosis, you typically hear parents report projectile vomiting. It should be non-bilious vomiting, and the infant is still ravenously hungry afterwards. With any vomiting illness, you tend to lose sodium chloride and potassium, and therefore, in pyloric stenosis, these are the levels that you would expect to be low. Because you're losing so many hydrogen ions, you also end up with a metabolic alkalosis, which you can see on your metabolic panel as an increased CO2 content. We can detect pyloric stenosis using an ultrasound, and removal of that muscle is the standard surgical therapy. Finally, we're going to talk about intussusception, something that's common in younger children who are less than 6 years old. As you can see in the picture here, the bowel has folded or telescoped onto itself. After it does so, it can start to swell, which then puts compression on the blood vessels and other structures, creating pain, distension, as well as decreased motility. Again, keep in mind that peristalsis has a lot to do with what we see in the GI tract. So this child will be in acute, sudden abdominal pain. It will be very impressive while they're screaming and crying. However, when the peristalsis stops, they may appear very comfortable. In addition, red currant jelly stools is a common question on tests asking about intussusception. Here you can see an example of an ultrasound where the bowel has telescoped back onto itself, making it look like a bullseye. The treatment for this is typically just going in with an endoscope and blowing that telescoped bowel or folded bowel out and back to where it needs to be. This can be accomplished with gas, such as in a pneumoenema, water, or even contrast agents. The refolding or reintussusception after this is performed is very rare.